So good morning, ladies and gentlemen. Well, it's going to be a very tough act to follow because actually, on the one hand, I consider Ola a leader in MRD testing in the MRD field, and I can only speak to this really as a humble clinician. And I think that's my agenda today, because actually Ola and I very much agree pretty much on everything, in fact, in terms of myeloma philosophy. And all I would simply say to you this morning, and I apologize for sort of making this sort of rather objective in that sense, is that really my position on this is that MRD testing is absolutely ready for prime time in the research and regulatory arena. The question for me as a clinician in my clinic is, do I apply it to everyday practice? And I would simply suggest to you at this point we're not ready for that. And we're not ready for that for a variety of complex reasons, and I hope to build them out for you. But I want to especially thank Ola for a lovely and very kind of warm and personal introduction. I apologize, my talk's going to be a little bit sort of more straight down the line. So again, with that in mind, what I wanted to share with you is the following sort of caveats. And the critical caveats relate to how we would apply this in clinical practice. So let's define MRD. First of all, it's any approach aimed at detecting and possibly quantifying residual tumor cells beyond the sensitivity of the level of routine imaging and laboratory techniques. And I'd simply suggest to you that in day-to-day practice, right now, the definition is somewhat fluid. And it varies obviously between diseases and technology used. Now, obviously, we recognize that MRD is very important. For most malignancies, there's a range of malignant cells that are still undetectable with conventional methods. And we recognize in hematologic malignancies in particular, and increasingly in myeloma, that the achievement of a complete clinical remission and assessing this needs a variety of different scenarios. Now, in that context, we obviously want to establish the full eradication of the neoplastic clone, and we want to determine the long-term persistence of quiescent or non-clonogenic or immunologically regulated tumor cells. And we also want to look at the persistence of clonogenic cells capable of giving rise to a full clinical relapse within a number of years. And I bring this to your attention because for those of us in practice, we recognize that this is a real phenomenon in myeloma. And as you heard so beautifully from the talks from Gareth and from Nikhil earlier, the extraordinary heterogeneity of myeloma is one of our most fundamental challenges. So let's just bear that in mind, because again, I'm just suggesting to you some caution here as we interpret the use of MRD. Now, the determination of MRD by sensitive molecular techniques can certainly identify patients with residual disease at the molecular level, and it may permit the analysis of treatments that induce a greater depth of response. And it may, of course, also identify patients who are relapsing early and will need further treatment. This is all an area of active exploration. But the question is, should it dictate what you and I do every afternoon in clinic with a particular patient, for example, outside of a clinical trial? So let's think about this in a more broader brush. If we look here at this particular slide and look at leukemia, we can see that in the context of ALL, for example, it's a secondary endpoint in clinical trials. And basically a workshop back in 2012 was part of that as an endpoint from which they've then gone. In AML, the story is quite similar. And indeed, in APL, it remains a secondary endpoint. In CLL, it is also a secondary endpoint of clinical trials, with again a workshop more recently, a few years ago. And CML, again, the same sort of construct. Although now, of course, in CML, we have it as a primary endpoint that does dictate a practice. And I would applaud the field in that area because obviously molecular response accepted as an endpoint for FDA for second-generation TKIs has been a bedrock of that approval process, and it now applies in clinical practice. Obviously, that's where we'd like to be, but I would suggest to you, just again, with a certain moderation and a certain amount of caution, that we may not be quite there yet. Now, when we look at lymphoma, for example, it's a secondary endpoint, and in mantle cell, exactly the same. So my hypothesis or suggestion to you this morning is that whilst MRD clearly is a vital area of research, and I especially applaud Ola for being on the forefront of this, and I fully support all the points he made, I would just simply suggest to you that it's less advanced than in leukemia and lymphoma, and we are currently in the point where MRD assessments are clearly secondary endpoints, an important research tool. But are we in the position to actually, in everyday practice, adjust our treatment? Do we know the difference between MRD positivity at a certain level in one treatment arm of a trial versus another? We have compelling data from early studies in this regard, and Ola touched on them nicely, particularly the daratumumab work with Lendex, and of course our own work with our French partners in the IFM, and I'll come back to that in a little while. My critical point, though, is that it remains a research tool. And why? Well, because in this context, we've obviously been blessed in the last decade with remarkable combination therapies that have been able to, in some way at least, abrogate some of the extraordinary genetic complexity that you heard so nicely about from Gareth and Nikhil just a few moments ago. The critical point here, though, is that whilst we're more successful in terms of these triplets, quadruplets, and now with the introduction of monoclonal antibodies and similar approaches, we're able to throw a bigger net around our disease. We're not able to eradicate it completely, and cure remains in myeloma, frankly, evasive. And I think that's a critical point. We thought, for example, that immunotherapy, could this be the mutationally agnostic approach that we had hoped for? Well, no, it isn't. And it makes clear sense, actually, because if you think about it, why did it happen in the first place? Immunology is not going to overcome every genetic variation or variance that there may be, and I think the evidence for that is now mounting. So let's just have a little word of caution in this context. So, moving on to the next step, and I think my buzzer's stopped moving. Oh, here we are. Sorry, beg your pardon. Go back one. Okay, let's go back. Sorry, apologies for this. Go back to this one. Right, okay. So with that in mind, basically we need to recognize that there are a variety of strategies for molecular response monitoring, and that's important. And when we look at flow cytometry versus other strategies, a couple of points to make, which I think you're all familiar with. There is variance, and I think that's a critical point, and a difference in applicability as well as sensitivity. Now, this is a slide from Nikhil, which I'm very grateful for, but it simply gives you an idea of new technologies in this field, and next-generation sequencing is a very exciting new direction. And Ola already touched on some of this, so in the interest of time, I'm not going to dwell on it, but simply to bring to your attention that there are a variety of strategies with different sensitivities that are being deployed, and some hold great promise. For example, this particular next-generation sequencing method, and in this context, the advantages of it, that it can identify all clonotypes, and it can also determine the frequency of each clonotype as we go forward. I'll spend a little bit more time on this, but move through it relatively quickly. As you can see, using this sequencing-based method that has higher technical performance, you can see variances and improvements in sensitivities. So when you compare these strategies, you can see variances as summarized on this slide, and show us that indeed, in the context of what we do technically, advances are being made with greater sensitivity comparing sequencing or next-generation sequencing to flow, and that's of course critical. Now we also of course have the ability to identify myeloma clones from peripheral blood, and this is a whole area that's evolving in and of itself. Now obviously, as you heard from Ola, there are a number of studies now that have been in process or are completed or indeed underway in which MRD status is obviously being evaluated prospectively. And what we do know is that MRD can be predictive of outcome both pre and post stem cell transplant, and this particular analysis supports that view. Recognizing, however, that in our MRD negative patients, we are still seeing significant treatment failure rates, and that's an important takeaway as we go forward. Obviously, we can associate MRD with response in terms of predicting superior progression-free and overall survivals in some combination treatment settings, in some, but not all. And we can also show that higher levels of sensitivity translate into improved time to prediction of time to tumor progression. But again, these are early data, relatively speaking. Now, I want to especially acknowledge Nikhil's meta-analysis that was just published this year and spend a little bit of time on it. Essentially, if you look at what they sought to do, it was to assess the impact of MRD status on PFS and OS in patients receiving treatment, and to determine if MRD is a better predictor of PFS and OS compared to conventional response. And I think the data here are very convincing, but let's dig down into them in detail, and let's also come to the conclusions that Nikhil and his co-authors put together. This is basically how the meta-analysis was done, and essentially what you can see is that there were 13 PFS studies and 9 OSS studies that were looked at in correlation with response as part of quantitative synthesis and meta-analysis. And this shows the number of articles reviewed in total, the number of patients assessed for both PFS and OS, so a very robust assessment. And this, in fact, was an analysis from the paper showing the effect on PFS and OS. So, again, convincing. What's also very impressive is for CR patients, the difference seen. So, certainly guiding us that we can move forward using this tool in the assessment of outcome as part of clinical trials. No question about that. And if you look at MRD versus negative versus positive patients in terms of OS, the CR data can similarly translated. But these are the critical conclusions that Nikhil drew. It is indeed predictive of longer PFS and OS,
Most of the results are derived from flow cytometry, recognizing that NGS is emerging now, but still is yet to be defined. And this is the critical point, that Nikhil concluded it is time to utilize MRD to direct therapy as a research tool and a regulatory endpoint. So I would humbly suggest that perhaps it's not ready for clinical prime time yet. And why is that so? Well, a couple of things to emphasize. Some factors affect MRD limitation detection methods, and they're summarized here, and I think they're fairly obvious. And this, of course, points to the reported limits of detection among 91 labs that perform MRD testing for myeloma. This is an important slide because it's real-world data that shows you some of the variance between the clinical labs that we have. So while some labs report a LOD lower than 0.01%, other reports their LOD as high as 1%. So in the clinical scenario, we're facing some real challenges. So the summary, there is a major heterogeneity in how the labs surveyed define MRD for PCM by flow cytometry, recognizing that next generation sequencing is coming, and especially in that context, we therefore need to see the results of studies to support that particular approach. Now, obviously in leukemia and lymphoma, flow cytometry are laboratory developed tests, but there are national and international efforts that are trying to get this under a standardization and harmonization that makes sense, not least of which because of the economic pressures that are present, and also to reflect current therapeutic practice. Now, I want to close by just touching on the IFMD-FCI trial that Ola so nicely showed. This is a critical forward effort, and I applaud my French partners because it's a remarkable work, particularly on their part and with the leadership of Michel et al. And what you can see here is that MRD negative patients do indeed do better than MRD positive patients. What always strikes me as a clinician, though, is we still have a significant treatment failure rate for the MRD negative patients that we need to do more for. And as Ola pointed out, clearly for PFS and response, the transplant early arm won. What's so interesting is that there was no difference in overall survival. And that's a very important point as we soberly look at these data and judge what they mean for each patient. So the take-homes. MRD in myeloma routinely being used in the setting of clinical trials after induction remission and after AST, sure, as a regulatory and research tool. Flow cytometry has been a mainstay, but I would propose that NGS is really the future. And in terms of its use for prognosis, obviously that's correct. But what's critical is therapeutic adjustment for what? What is the difference, for example, in one arm of a trial of 20% MRD positivity versus 40% another? And what does that really mean for overall survival? These are enormous challenges that we still face. I do think the lack of standardization broadly across the country is a challenge. And so with that in mind, I would simply suggest it is not yet a standard of care in clinical practice, but maybe. And thank you very much for your kind attention.